afternoon, ladies and gentlemen. Thanks very much, Christoph, for the introduction. I'm going to chair this session. Thank you all for putting aside time to join us here. As is clear from the title and Christoph's introduction, we're talking here about addiction treatment systems. So this is one of the sessions of the last few days that is less about practice, although we'll touch on issues of practice, but it's about treatment systems, how they're organised, how they're funded, and whether they're effective or not. It's an international session by its nature. We have speakers here from the UK, from the US, and from Turkey. And there are two things generally I say in terms of international sessions on any specialist subject. First of all, bear in mind the language. I should say that specifically in terms of Elif, who is not speaking in her first language, so bear in mind in listening and speaking in those terms. But also for myself and Ray, we speak versions of English. But I know Ray's an American version of English. Mine is a UK West Country version, which is barely English at all. But so I'm going to try and moderate the broader aspects of my accent, and ask all of you when you do make contributions, because we will be having discussion later, to bear in mind it's an international audience and to be aware of that. But also, and this is a trick always when I'm involved in international meetings, is jargon. We all have a lot of jargon that we think that everybody is going to understand when we say it, particularly acronyms. Now I'm going to say, I promise you, at some point in today's session, I'm going to say NTA. And I also promise you that half of you in the room won't know what I'm talking about. The other half will say, oh yeah, that's the NTA. It's not an important acronym, but basically we're all going to do it. So we all need to try, particularly when we're in international sessions, not to use jargon that we assume that everybody else is going to understand, organizations, structures, professional phrases, So please, we'll all try as best we can from the speakers platform, and also when you're making your contributions, be aware that what we think everybody knows, they may not know. Well, I want to organise the time. We have an hour and a half here, 90-minute session. The first half of the session, I think, very much traditional. We have three speakers. I'm going to ask each of them to present for 15 minutes. When they've presented, questions to that speaker, particularly around the specifics of their presentation. Once we've been through that, that should be around the hour point. When we're starting to flag a little bit, I'm going to try and generate a much more interactive discussion in our last 20-30 minutes, specifically on this question of to what extent do we think our national addiction treatment systems are truly recovery oriented. So I'll be generating some thinking and asking your views on that. So as you're listening to the presentations, bear in mind that we are hoping for a bit of interaction the last 20 or 30 minutes. And the idea behind this session is that the fundamental idea is that people working in different countries on the same challenges, the same ideals, can learn an awful lot when you look at different countries' practice, but also different countries' systems. We all work within a specific system. We all get to know the limits of that system. We get to know the histories of our addiction treatment systems. We get to know the culture of the system, what models we use, what structures we use to deliver treatment, how it's funded, what sort of professions are involved. Now, those, in all of my international experience over many years, they are surprisingly different in different countries. What we'll assume in the UK, this is how things are funded, this is how what professionals are involved, this is who does what. It's not the same in other countries. So actually, when you look at other countries' systems and their models, you can learn an awful lot or get a lot of reflection on what you're doing in the system you're working in. So the idea is the more interaction there is between people working in different countries, different systems, the better. And that's what we hope to do next 90 minutes. No system is perfect, and I'm pretty sure we had a little chat earlier on about what we are going to present. None of the systems being presented today, UK, US, or Turkey, is perfect. Far from it. But what we're going to talk about is what we think we do well, what we think needs to be improved in our own systems, and what we've learnt from our own histories. That's how we want to spend the next 90 minutes. So, want you to get involved, particularly in the second half, but first of all we'll do a traditional presentation and panel. The order we're going to follow is first Ray Tomasi from the US, Massachusetts, Elif Mutlu from Turkey, Istanbul, Elif, yeah, and then Noreen Oliver from the UK. So we're going to take it in that order. So with that, I'll pass to Ray Tomasi to start us off. Ray.
you, Michael. Boy, I have to talk, hold a mic, and use this at the same time. That could be a challenge for me. Well, thank you all for coming to this session as we come to the last day here at iCAAD. And I would say before I start, I'll give you a little thumbnail about what I hope to accomplish. But I do want to say that being here and being in the company of folks from different countries and hearing perspectives, understanding what some folks do and looking at what we do in the U.S. and what I particularly in our organization has been very enlightening for me. It's been I hope it's been as enriching an experience for you as it has for me. I am with a program in Massachusetts on Cape Cod, and I've been doing this for a long time. And to Michael's point, I think when we look at the history of our field, it really isn't that long. So I've been doing this over 40 years. When I first came into this field, we had a small little program, and it was located in a hospital. The hospital didn't like us being there. They, generally not very favorably inclined toward addiction patients. And I remember one day the administrator of that hospital decided that we were no longer going to provide food service to that wing of the hospital. And we said, oh my God, well, we're in the hospital. These are patients in the hospital. I said, we're not going to bring you, you'll have to figure out something else to do to get food for your patients. Well, we were quite flabbergasted by this position, but we had a plan. We came up with a plan very quickly. We decided we would do what most places have to do in emergency situations. We called the American Red Cross. And the American Red Cross came. Oh, and we also decided to call a local newspaper. So we had the next day, a picture in the paper was of the Red Cross worker spooning soup out of a pot to feed patients who were in a hospital. Needless to say, the day following we had food back. We've come a long way from that. What we're going to talk about today with recovery-oriented systems of care has been a little bit slower to come to the game. But I wanted to begin this by providing some context, and also I think the context will feed into the whole business of recovery-oriented systems of care, because the care that we provide for the most part in the U.S. is very episodically driven. People go to a program, they complete a program, then hopefully they go to the next thing, but the connections are very, very thready. When we look at, I'm going to give you a little snapshot of where things are in the U.S. Perhaps much of what you hear about the U.S. is about opioid overdose deaths, and certainly that's critical, nearly 50,000 a year. The number is climbing despite efforts, pretty wide-scale efforts to try to impact that. You may know this is really staggering to me. I mean, we're the big dark blue line at the top of this slide. Massachusetts is 7 million people. Last year, 250 million opioid pain reliever medications were in that community. So it's enough really to supply everybody in the state for a month. Tremendous efforts have been made by the governor and the administration to reduce that. At the end of the first year of an effort, it's reduced the number of those pills in the community by about 10 to 12%. We still have not gotten prescribers on board to begin to limit the access to prescription pain opioids. And we've heard much about, you may have seen this sort of thing, much about the heroin overdose deaths. I always point out to people that the number of heroin overdose deaths in the U.S. in 2013 were roughly equivalent to the number of prescription opioid overdose deaths in 2003. So we have an epidemic, I prefer to call it a crisis, but we have an epidemic, if you will, that's about in its 18th year of ascendancy in the U.S., not something that you can turn around in 1 or 2 years. This tracks prescribed opioid sales, deaths, and treatment. You can see that they all pretty much run in parallel to one another. This is a very I think an interesting piece of information because it starts to bring the opioid issue beyond the area of opioid overdose deaths. So what we've seen in the U.S. in the last year and a half is the decline in life expectancy. And the decline in life expectancy is primarily due to overdose deaths. And I have a couple of here that even more dramatically point this out. So I think we're trying to get across to policymakers is that this is not something that's confined to a narrow swath of the population. This is affecting big issues in the country. All-cause mortality, ages 45 to 54, the U.S. Caucasian population is the red line. You can see where we are in comparison to every other country. This is even more staggering. This is mortality by poisonings or overdose deaths, suicide, chronic liver disease, and cirrhosis. White non-Hispanic population, every age category, we're seeing significant increases in mortality. This is not something confined to a small sector of the population. Here it is by cause: poisonings, suicides, chronic liver disease, all significant increases. Look at that red line of poisonings. I mean, it's absolutely staggering. This is, I think, something that also speaks to what we want to talk about with recovery-oriented systems of care. This is, I have to confess that I have in university, my first degree was in economics, so whenever I do a healthcare thing, I always throw something in here about economics. But this is important. This is what we call labor force participation rate. Only 63% of work-eligible people in the U.S. actually work. But it's that inset that is particularly striking to me. It's a paper by Alan Kruger of Princeton. It's just done last year. Half of the prime age workforce eligible men who aren't working are on a prescription opioid. Now, we did a calculation, I think the other night, we determined that that's 15% of the adult male population in the US. So when you begin to think about the scope and the impact that this crisis has had on the society, it's staggering. And we could go on and on with impact on families and single parents and that sort of thing. So that's what we're facing in the U.S. It's not going to be resolved with a single program or a single treatment experience for an individual. These are prescribing patterns in the country. You can see that they're all over the place. The dark colors are the heavy prescribing states, and it goes down from there. One of the things that we've tried to do in America is limit amount of first prescriptions for opioids. Most of the Northeast, which is, as you may know if you follow anything in the U.S., is different than the rest of the country. Limiting to 7 days or less, so you can any first-time prescription, only 7 days supply. And we also have a prescription data monitoring system in the U.S. in some states, not all states, that requires a physician to log into a system before they prescribe an opioid to see if there's been any pattern of abuse or overuse by patients or other physicians. That was mandatory in Massachusetts. We had about 52% physician compliance rate with a mandatory system. It's been changed, the system's been upgraded and improved, so that's getting better. So we've had very slow uptake with physician and prescribing patterns. You go to a dentist almost anywhere in the U.S. To have a tooth pulled or a root canal, you can almost guarantee that you'll go out with 30 Vicodin. Most people will take them for 2 days, and then they sit on the shelf, and of course you know what happens after that. So the context here is much broader than simply sort of drug-addicted individuals. This has significant effect on the economy, on healthcare costs, on productivity. And so what we're urging our policymakers to think about is a much bigger vision for how you address it. This is a situation that rivals Ebola and Zika. The investment that we've made in America to really create systems that have the greater potential to produce better patient outcomes, prevention, and early intervention just have not been done. We've had a very small voice, those of us in the behavioral health side, for really influencing the way investment takes place in these illnesses, but it's very, very disproportionate. We had a bill that was languished in the Senate for about 8 months. It was called a CARA bill, the Comprehensive Addiction Recovery Act. It finally passed after about probably 18 months of, I guess you'd call it debate. It passed with no appropriation attached to it. So if you know anything about that, it's like you passed all the bills you want, but if there's no appropriation attached to it, it's not going anywhere. So after about 6 or 8 months, finally they allocated $1 billion over a 2-year period to this bill, which is just incredibly under invested for what we need to do. So when we talk about this, what are we really talking about? And in America, much of the care that is provided, as I said, is very episodically driven. You go to a program, you complete a program, and over the years, I think what the general public has generally believed is if you go to a rehab program for a month, then that will be remedial. That'll take care of it. You know, we don't have to worry about this anymore. That's not the case. We know that's not the case. And we know that when you think about managing recovery, you're really talking about services that take place outside of the walls. Most people do pretty well in rehab. We run rehab programs. We have a number of different inpatient services at varying levels of intensity, and patients do very well. Well, they get up, they have a breakfast served to them, they go to a group session, they go to the fitness room, they go to the yoga class, any number of these services that we provide, which are all good things to do, but it's very, very difficult to get folks to be thinking about something that I spend a lot of time thinking about, and that is, what happens 72 hours after you leave that nice place and you go back to your life? What do you have there? And what are we doing to support your remission beyond what we've delivered in the acute setting? The American system was built on an acute care model. And it took us many years, I think, to come around to the realization that we had built an acute care model of treatment for a chronic illness. The match isn't there. And we have not done enough on the other side, on either side actually, either in prevention or in long-term recovery management. If you want to sort of go into the depths of recovery management or RSCs or recovery coaching, what some folks call it, read some of the works of William White. William White was writing about this 15, 20 years ago. These are some of the things that we try to do in our RSCs. You'll notice the thing here is that none of these are happening inside of the walls of a facility. So what we're thinking about here is how do we take treatment outside of the 4 walls of a center into the place where patients are, and so that we can support them not just in the necessary activities that one needs to do to sustain their engagement with treatment and counseling, but also to begin looking at those social determinants, the important factors in the community, whether they have to do with relationships, whether they have to do with employment, training, skill enhancement, education, the kinds of things that matter for long-term recovery. And really monitoring. One of the things that we went to a session earlier this morning on digital technology. I don't know if any of you, some of you were there actually. So that's very curious to me because it provides an opportunity to create what I call a digital loop between when we see people face to face. That's often when they need us. We use a very highly personalized recovery management program in our own organization where we assign an individual to someone who's with you in whatever your venue happens to be. I mean, we have folks who are 23 years old who are involved with this and folks who are 70-year-old involved in this. The real work with them begins on the other side of the treatment experience. And that's the sort of thing I think we're talking about. Do we have a system that really envelops the patient, engages with them, stays with them, and works with them to build up the supportive infrastructure of recovery after a episode of care? We don't have that in practice except in small pockets of places in the States, and we don't have it relative to policy. We have a federal entity that talks about ROSCs, but in really pushing implementation into the system, it's very, very slow to come. So this is sort of what I'm talking about, because this all matters. All of these things hold a very important part in how one pursues their recovery. And I think that the point to be made about this slide is that treatment and rehab is one element of the system. It isn't the only element of the system. So we need to begin thinking about this. Funding, reimbursement, and financing of all these things happens in a way that doesn't advance this. And many of the things that we find ourselves doing don't have real sustainable financial support. These are some outcomes. We've been doing this for about 4 years. So we have maybe 400 patients or so have been through this. The light lines are where folks were in the year previous. The dark bar graph is what we're finding for folks who have been in an ROSC, as we define it, recovery management program, for about, I think this group is either 6 months or 12 months. They've been in at least 6 months, I think. So we bring this to payers, and we show them basically that you can actually do very, very good things in increasing periods of remission, reducing detox days, reducing hospital admissions, almost eliminating new legal offenses, and in improving employment rates. All of the things that have to do with some of the earlier slides I showed you about work, life expectancy, mortality, and improved lives. We're not there yet. I think we're beginning to get closer. How am I doing, Michael? What do I got, about 12 seconds?
A few more minutes.
Okay. What's driving new thinking? It isn't necessarily guys like me who are saying, wow, we should do this, look how good it looks. When we bring this to payers, why do they like this? Because they can reduce their costs. So much of this comes down to, in America, of course, the healthcare costs, and whether it's the American Health Care Act or the Obamacare, I'm not in the country, so I can basically say, we don't know what the hell we're doing over there, I can tell you. I mean, it's really, it's almost farcical, when we see what's going on with this. We have a very sort of insurance-driven industry. People do what they get paid for. I mean, we can understand that. When we look at this and we bring it to payers, they say, it's really good, let us think about it. You might hear from them 6 or 8 or 10 months later. In America, 75% of individuals with private health insurance change their health insurance carrier every 3 years. So you have to ask them, what is the incentive for the health insurance company to really invest in long-term health of their subscribers. It's all a very short-term, short-run business. So it's very, very difficult to get that to get these kinds of systems financed in a way that really will begin to change patient outcomes. But clearly this is where we need to be thinking. We need to be thinking beyond the idea that a person can go to a treatment center and then magically 4 or 5 weeks later come back and be restored. Do people get better? And is rehab good? Yes, it is, but it's only one piece of the equation. And so these are the kinds of things that we need to be thinking about, certainly on the post-hospitalization side. On the pre-hospitalization side, there are great opportunities through the integration with medical care. Most people go to a doctor until the doctor doesn't want to see them anymore because they're not paying their bill because they're addicted and they're not showing up for appointments. But where can we do the most in the future for identifying high risk and intervening earlier when we're engaged and integrated with the medical system where people are still being seen? So we're doing some of this ourselves. Most excitedly for me, we just received a foundation award to begin doing it in a pediatric practice, screening, working with families, identifying those at greater risk, and applying an intervention. Maybe it's ADHD, maybe it's depression, maybe it's anxiety, but all of the things that contribute to the patient who will be seeing in crisis if nothing is done 5 or 6 years later. So again, I guess in sum, I'd say that what we're looking at here is broadening our vision for what treatment is, broadening our perspective on how recovery happens, where it happens, and with whom it happens, and what resources we need to bring to the game to make it happen. Because when you do it, we see great, great results. We know that if a person is in remission for 5 years, their likelihood of regression falls to below 15%. We need to get there. In Massachusetts, we know that of all the individuals admitted to a detox, in 1 year, 40% of them are the same people. Got to do better. Thanks.
Thanks very much, Ray. And as I say, I'll be inviting questions to Ray in a second. Thanks also to Ray for illustrating one of the points I made in the introduction is the US system, as Ray described there, historically is very much based around entering a program. Yeah? So the majority of people who enter into the treatment system in the US historically, and it will vary state to state, go into a program, whether that's a structured community program or a residential program. As you're going to hear from Noreen later, and I'm just going to flag it now, in the UK, the number of people who come into the treatment system in the UK who go on what you would recognise in the US as a program is a tiny proportion. Yeah? So the numbers of people in the UK who go into a program as the Americans understand it is a small proportion. In the US, historically, almost everybody will go in some sort of program. So very different systems, very different histories. The other thing, Ray, back to jargon, what's an ROSC?
A recovery-oriented system of care.
Okay, thank you. I thought that might be what it stood for, but I didn't want to assume.
And what's Paris? Is it importance of Paris?
I think that was with reference to payers.
Payers.
Yeah. See, now we're getting the international accents coming in. Yeah, Paris wasn't involved in the US treatment system at all. Payers, yeah.
Jersey boy.
Okay, any questions that came out of Ray's description of the US system and the challenges? Questions to Ray? Lady here.
Just in the approach to prevention, you said work being done with young people, other programs in schools.
Again,
That's probably all there.
again, it's very spotty and inconsistent. There's no systemic approach to it, so much of it is left to schools, and they may think that providing a health class about alcohol and drugs is sufficient. We've begun going into schools and have been invited, and we're in about 20 schools. Six of them are elementary schools, which is very, very good. When you go into a school, the school is essentially very glad that you're there because you're going to take care of all the troubled kids, which is, 4 or 5% of the kids. So we're looking now to work with them in much broader ways about prevention and how do you do a couple of things. How do you appropriate some of the things that other students are doing that don't result in drug or alcohol use? Can you use some of the existing kids? Can you use messaging? Can you do some things to celebrate, if you will, prevention type activities? But there are a number of programs that have shown by evidence to be helpful in reducing underage drinking. One of the problems with prevention, and we look at it much more from a community-based prevention view rather than a school-based, is that in order for prevention to show data that supports it, you need to do it over a period, over a time. You can't do it for 1 or 2 years and then say, gee, nothing's really happened in the community, so therefore we're not going to pay for it anymore, we're not going to fund it anymore. For every dollar, for instance, in our state, that gets spent on addiction-related matters, a penny goes to treatment, a penny goes to prevention, and 98 cents goes to take care of all the associated costs of the consequences, whether the criminal justice costs, mental health, education, family issues, other healthcare costs. So, trying to influence the change in the allocation of those dollars has been challenging. If there's any, I don't know if I'd call it a silver lining in the opiate crisis, it has raised the awareness level of politicians and policymakers. And frankly, in America, it's because this was not a crisis until middle-class white kids started overdosing and dying. And that then got voice of the middle and upper middle class who wanted something done. Those are the voters, and that then got political interest. And so that's how it sort of raised to that level. But to your point, we have much, much further to go in prevention.
Okay, thank you. Question here then, the gentleman there. Just realised that you need to speak into the microphone for the recording, so I'll bring it to you.
On the subject of prevention, there's some really good research that alcohol literacy programs can actually really reduce the sort of the drinking rates and very much moderate. And it's really set up about the expectations that middle schoolers and high schoolers have regarding alcohol use. So from a social context, those are very, very effective because in the States they've had DARE programs which are informative about the dangers of drug addiction, and in fact, they've had the reverse effects.
We've seen in the community that we're primarily, and we've seen significant declines in underage drinking, and I think your point is well taken. I think informative programs have very limited benefit.
If you could pass the microphone along to the gentleman there, and I've got room for one more question after this one if anybody's eager.
So I'm just wondering how you've got community integration, just wondering how best practice, how you do that, and also engaging and maintaining a relationship with working with family members.
When you say community engagement, you're talking about integration?
Yes.
Oh, okay, well, when we looked at the data, and we're sort of in a, healthcare has been the last to catch up with the data-driven society, if you will, and we saw the sort of repeat use of emergency services and the repeat use of acute alcohol and drug addiction services, and we looked at the potential there was to reduce that. We just saw that in America there are 25 million addicted individuals. About 2.5–3 million of them get treatment. Right underneath that 25 million are 60 million misusers or abusers. So where are they? they are in the mainstream of the society. And where do they go for their health care? They go to the doctors. And so we saw that as an opportunity. If we could convince a medical practice to embed a behavioral health clinician in their practice as part of their medical team, they're blind to our organization. We could assist the doctor through screenings and then through brief interventions, lifestyle modifications and management to perhaps help prevent bad things from happening down the road. Again, it's an investment that we made in that because there's no way to pay for it the way things are presently structured in the U.S. I think that has the greatest potential down the road. One of the things that we must remember about this crisis is that in any crisis moment, you need to do everything you can to help those in crisis. But the vision for how you prevent further crises or how you redefine your system needs to happen concurrent with that emergency effort. This is an opportunity we have to change the system. And I've used this, this is a great place to use this, when I sort of read American history, when I think about the first time that Roosevelt and Churchill ever met in 1941 off the coast of Newfoundland, the Allies had not won one battle, and the U.S. was not in the war. And when they met, the thing that they talked about most was, what is the new world order going to be after we win this? And I thought about that, and I said, you know something? That's the way we need to think about this crisis. Yes, we have to do everything we can now to help those in desperate need. But we need to be thinking about what does the future allow us to do to prevent this from ever happening again? Whether it's with prescribers, whether it's with prevention, whether it's with early intervention, integration with medical care, because if we're ever going to be consigned to the sidelines of healthcare and addiction treatment, we will always be operating in the emergency mode, and that can't continue in the future. So that's what we push for, and we do it, and then we try to produce the data that we can then take to someone and say, look, this will make a difference.
Okay, any more questions last question to Ray? If we could get the microphone, thanks.
Has anyone done any research or data collection on the cost-benefit economics on the integrated recovery system? Any proper
well, we know what
analysis?
We know what the cost is of not doing it. So if we look at those medical conditions and we look at them independent of any behavioral health comorbidity, and then we look at the patients who have either addiction and or a mental health problem, we know that the costs associated with the comorbidities and the primary health condition are 2 to 3 times greater. And the only thing that's driving this in the U.S. is that, and this is maybe gets a little bit too in the weeds and esoteric, is the way that we pay for care now in America is basically, if you give a service, you get paid for a service. So whether it's, incentivizing anyone to, the more you do, the more you get. We're trying to change that to what we call a value-based system, and where we actually say to the hospital system, we're going to give you $5 million to take care of all the people in your community. If you do a good job, maybe you'll make a nickel at the end of the day. If you don't, the risk is on you. So when hospital financial people start looking at what are the high-cost patients for them, they're the patients who have addiction and mental health disorders and also have a medical condition. And if they don't do something about that, it's going to cost them. So I'm not so sure that all of this is driven by sort of, good intent. But if in the end it results in a better care for the patient, what do we care?
Okay, thanks very much, Ray. There'll be more chance to interact with Ray in the last session. But I'm going to turn now to Turkey. Dr. Elif Mutlu. Elif is an expert practitioner, works in addiction treatment in Turkey, but also has responsibilities at their Ministry of Health. So sees this from a practitioner and an organizer side. So Dr. Mutlu, over to you.
Thank you.
And you may need help with the presentation.
Yes, because of my difficulties in language, I think I need more eye and face contact with you. I will keep on moving during my presentation. As Mike told, I'm working as a psychiatrist. My primary work is being a clinician. I'm working nowadays in a hospital, this Armenian hospital, in addiction department. And in my private office, private praxis, I have a position at the university. I'm giving lectures about addiction psychology. And what else? I'm making some research, academic job, I can say. And I'm working also for Ministry of Health, not full-time, not fully engaged, but I'm working in data collecting and interpretation and working for the focal point of EMCDDA, European Monitoring Center for Drugs and Drug Abuse. So it's complicated. It means I can say something today, tell something about Turkey. What's happening on the field, how is the structure, what are the developments and the challenges in Turkey, what's going on. So I'm talking a little slowly and I have about 26 slides. I will jump through, not tell everything. This is an outline. I will give you an overview about demographics. I find it important because there are huge differences between, especially European countries, the Western world, I can say, and Turkey. So really demographic differences originated from geopolitical situation, I can say, and history and culture. The majority of the Turkish population is Muslim. There are some obligations reaching drugs and alcohol, etc. So, prevalence of drug use, AMATEMS, this is an abbreviation. It means the public addiction treatment hospitals in Turkey. It means alcohol and drug addiction, what, like English, treatment, education, etc. station. So, profile of clients, there are some differences. Programs, this word program is quite new for us, and it's also a difficulty for myself also, transferring or translating such terms to Turkish culture when I'm with the Ministry of Health, with politicians, and vice versa. The structure, the system translating to the others. It's really challenging for me, but I'm getting adjusted. So, NA, AA, NGOs, and prospects. This is Turkey. Turkey has about 77 million population, and these are the most populated, the cities with highest population. This is Istanbul, where I am coming from. Istanbul has about 15 million population. It's huge. This is Ankara, the capital city. The third is Izmir, Bursa, Antalya, etc. This is the border of Syria and Iraq, the hot zone. It's an urbanizing country. This is the urbanization rate, higher than UK, States, and France. I took them from Eurostat statistics. They are quite new. Employment. Unemployment rate is a little higher than European average. This is the structure of the demographic. It means quite young population. You see the majority of the population is between the ages of 20 and 65. This is a difference. So in comparison to European Union average, for example, can you read this? They are very small. So this population by age classes is different. Turkey has a quite young population. GDP per capita, you know better than me probably, this means income standards. if you take the European average 100, Turkey has 53. So unemployment rate is in Europe 9%, etc. Not important. And the location. So Turkey, this is the Afghanistan, and this is the classical Balkan route of heroin. Heroin is coming from Afghanistan with 3-4 basic routes, and the golden route, one of the traditional classic route, is the Balkan route, coming directly to the east side of Turkey and through Turkey spreading to Europe. It means Turkey is a transition country of heroin, but probably with the young population, with the changes in the age of the population, with this new young population, Turkey is becoming a target country, not only for transition, also target destination. This is important. So what about the prevalence? This is this study published last year, 2016. You can find the details. Lifetime use of drugs and alcohol. I have to conclude that we don't have really good prevalence data, national prevalence data. European School Survey and ESPAT is not approved by Ministry of Education for applying at the school, so we don't know the situation in young population. But I can say that illicit drug use and also alcohol use is lower than European countries, but it's still a problem. What about treatment? Turkish addiction treatment system is totally engaged to a medical pattern under the control of Ministry of Health. So usually doctors, psychiatrists are working in this field about addiction treatment. We understand detox, such terms, aftercare, recovery, continuous care, such terms is really difficult to transfer to Turkish system. But nowadays some things are changing. I will explain later. So AMATEMs are huge public detox and short rehab ICANs, maybe for 1 month after detox. They have programs. AMATEMs are the main public hospitals for addiction treatment, both alcohol and drugs. There are some programs rather than AMATEM, but quite new and not so frequently, NGOs and self-help groups. There are 41 inpatient clinics. It means AMATEM in Turkey, all among Turkey, 477 million. About 97 is public, 7 university clinics, and 5 private hospitals. I think it's also important and different from the rest, social insurance. All of the addiction treatment in public facilities is paid by national health system, health insurance. So it has some consequences, measurement. Concrete, reliable measures are failing because nobody's controlling the money. Second, the quality and different programs, lack of different programs, I think. The capacity of all inpatient beds among the country is about 1,975 beds, and majority of them are in AMATEMs, in public hospitals. Where I am working is a private hospital, for example. I was working in a big AMATEM before, then I started to work in a private clinic. This is the outpatient centers. Outpatient treatment, outpatient centers, such things are quite new. I can say started or accelerated in 2015 after a crisis happened in Turkey. Now they are in public hospitals, university clinics, and 2 private hospitals have also their outpatient treatment centers. Okay, the comparison of the diversion of beds, inpatient, outpatient, very limited. This is the profile of the client. It means for inpatients, what substances are the clients consuming? We can only make measurements in admissions in public hospitals, and it shows us the opiates are the number one. And also, and the second is, you see here, other new psychoactive substances. It means during the ICD system, International Code of Diagnostic, European Diagnostic Coding System, synthetic cannabinoids are coded under other substances. So, and the synthetic cannabinoids there was a craze in Turkey before 3 years ago, and still there is a huge problem with synthetic cannabinoids. And it shows us usually the synthetic cannabinoid users. For the outpatients, opioids are again the first. What does it mean? Of course, in general population, the mostly used substance is not opioids. It's cannabis, like the others. But directly, drug-related deaths shows us the most toxic drugs. Indirectly, drug-related deaths, the ratio shows us the most common substance used in the community. So, opioids are used and are in the first rank in treatment, these clients. And cannabis and synthetic cannabinoids are the most frequent used substances. Why are those people driven to the clinics in the first hour? There is a difference in comparison to, for example, Netherlands, Germany, etc. Because the first time this medication, opioid substitution treatment, not methadone, but Suboxone, is available in 2010. That means, and it only allowed in AMATEMs, in such clinics. That means hundreds, thousands of opioid addicts are driven to the clinics, entering first time to the treatment. This is controversial. For example, in European data, the first time people entering first time to the treatment are usually cannabis users, not opioids. But in Turkey, since 2010, there is a dramatic change in profile. Other programs I want to, how many minutes do I have? 5. Okay. I forgot to conclude that. I am working as clinical supervisor in 2 different district centers in Istanbul. And these centers are working with C4 recovery organizations. So in collaboration with the local municipality and C4. And I'm the local supervisor of such centers. And as a sample, I want to make a brief report about those models. This is a center in Avcılar. Avcılar is in the western Istanbul, close to the airport, maybe you know Istanbul. About 900,000 population, and this is a center in collaboration with C4 and Avcılar municipality. It has a program. It has a program developed by Bob Lean according to Turkish society's needs and challenges, but it's a very American program. And for the policymakers, for the staff, for the clients, it's somehow difficult to understand the sense of the program. For me, in the beginning, was it also. So we have a staff like this, individual psychotherapy, family therapy, educational groups, 12-step information sessions, etc. is done here. It has some strengths and challenges. this center has direct contact with the detox center. This is important again because almost all of the clients and families and also the politicians are asking such institutions for inpatient treatment. We have a patient, we have a client who needs immediately inpatient. Whatever the drug is it's not important, but the demand is still like that. So we started to make a direct contact with detox center. It means we have some beds there. And local psychiatric services, Avcılar municipalities, social facilities, other NGOs in Avcılar, NA meeting group, and some scientific sources. We are collecting data and some meetings. Challenges are that demand is very different, and this program, I say, is quite new and not so easily acceptable, not satisfying the demands of the clients. This is the challenges, but getting better. Is there any harm reduction policy in Turkey, for example? Or is the Turkish drug treatment policy recovery oriented? No and no. For example, syringe needle exchange program, there is no program in Turkey. Opioid substitution treatment, very limited and restricted, only in AMATEMs, it means in 50 centers all among Turkey. There is no methadone, no other substances, no heroin-assisted treatment, and there is no legalization or decriminalization, such changes in legislation and law. Probation started in 2009, and Suboxone is available since 2010. Yeah, there are close to harm reduction. Okay, then, is Turkish understanding recovery oriented? Maybe, not totally. AA and NA, yes, they exist in Turkey. AA is quite older, but NA is in 1993. 12 groups among Turkey, in Istanbul 6 groups, and 18 meetings per week. They are contacts with detox clinics, AMATEMs, and other private clinics also. NGOs. It happened something in 2014 and 15. There was a craze, especially on the media. People, suicide attempts, people using synthetic cannabinoids, etc., etc. This drug abuse problem took maybe first time so much impact role on the media, and the government took action. They established a committee consisting of 7 different ministries: Ministry of Education, Health, Ministry of Youth, Ministry of Internships, etc. And started to develop policy. So, and they started to fund also the NGOs. There is really, it's also controversial to the others, I think. In Turkish system, Turkish government especially is spreading the money to addiction treatment since 2-3 years. This Turkish Green Crescent is a very old NGO from Ottoman times, but it was very passive, inactive, and now has direct relationship to the government, to the president, to be honest, and a huge impact, money, and power on the community. It is the most famous NGO in Turkey, I can say. This is another NGO if you are only interested. So what is the prospects? Prevention, treatment, and rehab programs and models. It's the first time spoken in Turkey, slowly. For prevention, the Ministry of Education and Green Crescent is in responsibility. Improving the capacity and quality, establishing new AMATEMs, but under the control of Ministry of Health, training staff, education in this area, etc. And residential or outpatient short-term or long-term rehab services with other ministries. They are in progress. There are some samples in Istanbul, in Ankara, but we don't have any inpatient rehab facility in Turkey. No. Outpatient, there are some only projects, a level of projects. It's not very common. So it was a photograph from Turkey, but I think you will have questions and we will go there. Thank you.
Thanks very much, Dr. Mutlu. Questions for Elif? Stay near a microphone. You will have seen that we're moving along and using up our time here, so the amount of time for open discussion towards the end may be limited. But as I say, it will be a chance to put questions again after we've heard from Noreen. Okay, so now I'm going to bring us back to the UK. Noreen Oliver, well known to many of you, I'm sure, has worked for many years and organised services in Staffordshire in the Midlands, and is going to talk to us a little bit about the UK system and its challenges. Noreen.
Thank you. When I I think I'm going to be the one that's going to have a problem here. Good afternoon, everybody. Okay, when I started to put this presentation together, I got a little bit depressed, as you'll see later on in it, because there had been all the good work and the policies that that Mike had been involved with, and Anthony, and that we all did together, and the manifestos that we did when this government came into power in 2010. The figures that I've got on there are from the National Treatment Monitoring Data, so it is the NDTMS, but also Freedom of Information. Through the Recovery Group UK, we put a Freedom of Information request into every single local authority in this country, as in England. And we wanted to know what their spend was going back 2 years on treatment and then rehab, and now going forward to 17-18. So those figures are from the Freedom of Information and the others are the NDTMS. I'll go the other way. Okay. So, when this coalition government came in, we heard quite a lot of noise that they were going to challenge the status quo, and people had drifted in far too long on methadone. So there was various statements that came out, and under here, I think you'll recognise some of the names there. I was actually at the talk by David Cameron when he talked about people stuck in the system and nothing else. You can see that we've got our Home Secretary, who is now our Prime Minister. So this was what we're all looking forward to. We're all looking forward to working together, to building a recovery system, and by that I don't just mean treatment, I mean housing, education, employment opportunities and social enterprises. So, the new government is in, and they now start to devolve the power down to the local authorities. Commissioners start to prepare for the ambitious new recovery-orientated system that we're going to have in the UK. Agencies, now that was really good. Agencies start to work together, so harm reduction and abstinence services start sitting across from each other. And we formed the Recovery Group UK, and on that there was a lot of harm reduction and abstinence rehabs and various services, looking at how we could put together a seamless pathway for people to refer through. We started up the Recovery Group UK, the Recovery Partnership, and the Recovery Partnership, I was a co-chair of it, reported directly to the interministerial group on substance misuse. And from 2010 until 12 months ago, I think we went there twice, and it was on and it was off and it was on and it was off. But really, it was all sort of put on the back burner. The drug strategy comes out and it talks about this ambitious and our treatment system and putting full recovery first, which actually a lot of people were not happy with that document because they felt that it went too far into the abstinence field. But every single department in government stamped that document, and it came out on a Friday night, I think, hidden on a website. So it's a lot of people didn't even know that. We started to develop recovery housing. So what happens when somebody comes out of rehab? You know, housing, how do they live independently? How do they pay their bills? How do they get a job? How do they get further education? And the acceptance of mutual aid, because those of you who've been around a long time will remember that a few years ago, not so long ago, before 2010, AA and NA were not popular because there was this myth that it was about God. So that starts to come in, and actually in some areas NA and AA were really the mainstay of their treatment plan. Capital investment for recovery systems, so that's for in that capital investment we had BAC in Staffordshire, we brought a 24-bedded unit and a lodge to deliver the services in Staffordshire, and with the capital monies of £1 million. That closed just before Christmas. So that's happened across a lot of areas, and I don't know how much we had. We must have had at least 20-30 million over a few years that went out, and people. Did you do some, Steve, as well? Did you? Yeah, people right across. I mean, we've still got our recovery houses as well, thank goodness, because they're so important. Payment by result. We were having payment by result. There was no negotiating. It would be payment by result. So we had 8 test sites to do payment by result. They were buried. It didn't work. So we moved on. I'm sorry that I'm your merchant of doom this afternoon, but you know, this is what we have, this is what we had, and this is where we're going to. The drug and alcohol money was ring-fenced for at least 10 years, and that was removed, so the ring-fence came off. As I say, the results for the payment by result. And out of 100 public health, which sit under the local authority, 112 with significantly reduced local budgets, and they go from 9% to 59%, and that's on the freedom of information. We wanted to know as well the treatment budgets and the rehab budgets, and so we asked and split them out. When it became local authorities, services across the country varied. You know, it was what would be delivered, the local authority, and the money was now in the hands of the politicians. So we have workers that are carrying huge caseloads, you know, in one particular area. Under the freedom of information, they told us that their workers were carrying a caseload of 100. Across a large area, they had 1.5 for a community detox nurse. So it's all, although we've had reductions over the years, I think this April and going forward, and certainly next year, is where some of the other cuts are going to come. Social interventions and some of the specialist services are now having to sit on the side because some particular areas are only just doing the prescribing. They're doing what their budget is. And we're losing some really experienced, skilled workers from the sector. You know, there's been a lot of redundancies, and we do have people that have worked in the sector for a number of years, and actually people that built this recovery system. And it was, you know, when it was working, it was a fantastic recovery system. Rehab referrals and admissions have reached dramatic levels. 11 rehabs have closed. 3 rehabs have had to sell off their assets to survive. 4 units of the recovery housing have closed. And in that, what we've got is that we now have in some areas where they put the client into the recovery house, and then they claim the housing benefit, and then they send them to AA and NA. And Little and David's sitting there nodding his head. And our main contractors, you all know that we have some very, very large agencies who are able to pick up all of the contracts, and then they determine if they're going to have a rehab budget, because they hold that from the local authority, and they determine who is going into further rehab aftercare services. So we've gone back to provider gatekeeping another provider. I mean, I think it was like that 20 years ago, and it's so that was the key that services were worried about. You know, because they've got used to referring people to rehab, they've got used to referring them to recovery housing, got used to working together, and got used to seeing the results, because that's the most important thing. Referrals fallen by 50%. A lot are saying that they're only taking private referrals now to survive. And we had a review of the drug strategy, and it was coming out, and David, then it was cancelled, and then it was coming out again, and then it was cancelled, and then David Burrows MP stood up in Parliament and asked for a search party to find this drug strategy. Well, to what extent can the drug and alcohol treatment system be described as a carefully planned national system? That was my question, and I think you all know the answer now. So, these are the numbers that came out of NDTMS, 14-15, so the most recent ones. So the number in treatment, and then broken down. Now, alcohol said 89,107. This is that's actually reporting to the NDTMS. So that's what we've got in clients. Not in a million years. So I looked up alcohol concern and got their figure, which was more the 1.6 million. There's no way that we could just have 89,000 dependent drinkers. I think some of the concerns are that alcohol's now going to take a back seat, and it's happening in some areas that it is just drug funding, and I'm talking about all of this. And if you'd have asked me a couple of years ago, or if you'd have asked me at the beginning, we had such great high hopes. We really believed, and we worked really hard with the government and officials, because we really believed that we were going to have this system. So, I wouldn't have been standing here saying this. I would have been sort of talking about this fantastic system, and that's what I presented before. But this is the reality, and local authorities are deciding, what they spend and where they spend it and what they're buying, or some of the big charities. That's the housing benefit model that I talked to you about. Prescribing only, and if you think about that, and your psychosocial, and you've got a caseload of 100. There's an increase in emergency NHS admissions, because in a lot of areas that is the only place that the alcoholic can go to get speedy treatment and to actually get a detox. So we're going to see, we used to see criminal justice because they used to say that's the only way that they could get into rehab, to start committing offences. Now we're going to have alcohol dependent people going into emergency NHS, and it's the only way that we can get through. Now this one here has reached a level that has never been seen before, and I think most of you who work in the UK will have your areas where you've seen drug-related deaths increase. It has now gone to a level that we've never seen before, and I think that it's, we need to start doing some real investigations on, what is behind the drug-related deaths and how we can learn from that practice. So I was asked to put up what our treatment modalities are in England, and the usual. I mean, there will be some there that some that are not on there that you will think about afterwards. But this was the whole array of what we're putting together. I'd love to meet all of you in 12 months' time and say, where are we now? What is happening now? Is there, has a miracle appeared? And they were concentrating on the drugs budget, but, I think, or I know, that now we're dealing on Brexit. Nothing else is happening other than Brexit and Donald Trump. I said to somebody today, I see more of Donald Trump on our TV than Coronation Street. It's a reoccurring practice. So those are all the services that are out in areas, and as I say, they vary greatly. And I think one of the huge concerns has been the experienced, skilled workers that we're going to lose, that are out there. And we're going to have to start all over again to start building this recovery system. Thank you.
Thanks very much, Noreen. And that last slide there reminded me that when we tried to build up a national system of addiction treatment in the UK, and it is 20 years ago, when we started investment in a national system, we had exactly that vision, that menu of services from that last slide. The idea was that all those services would be available in every town and city in the UK, and they would all work in efficient integration with each other to create a recovery-oriented system. That's 20 years ago now, as Noreen says. 7 years ago, there was a new government and a new rhetorical push for that system, but not a lot has happened since, and we don't even have a strategy anymore. So yeah, on that bright note, thank you, Noreen. We've got some time now for open discussion on the 3 country experiences we've heard. I'm going to ask each of our panellists to say if they got any more to reflect on that final question that Noreen addressed, which is to what extent is your country's system a system, and to what extent is it recovery oriented. But I'm going to be asking for contributions and questions from the audience after our panel has spoken. Just a few reflections if you want. Ray first.
Well, I would concur. We don't have a well-oiled or well-defined system. We have a lot of services, but many of them are unlinked. Even in organizations themselves, those services are unlinked. So there's very poor transitions to next levels of care, if you will. There is a federal entity under the Department of Health and Human Services that oversees they still call it substance abuse and mental health services in the country. And they make efforts, but I guess the one word that continually comes to me is fragmented, undisciplined, and disorganized in its approach. And part of that is because there's no philosophical foundation that is universally agreed upon about how to approach these issues. I mean, we have harm reductionists and we have abstinence folks. They seem to create these extremes in ideological positions that are more important to them than whether or not both or either of those two approaches have benefit to patients and to families. And I know someone asked about families earlier. There are family services, but they too are very fragmented and disassociated.
And if you did notice one thing from your presentation, you did mention about the financial systems in Turkey. On the one hand, you said there is nobody in control of them, but it was a state-funded system. It was free for the patient. Yeah.
Yes.
Do you see there's a potential there in Turkey for somebody to build up a national strategy?
A system without control, I know generally the healthcare system of addiction is generally under the control of the Ministry of Health and paid totally by the social security system for each individual. It means money comes from the government and goes again to government, the public hospitals. The lack of control, it's not a lack of control, but also the costs, the fare are not so high. And but with the change in the policy since 3 years, they are also encouraging the private sector. For example, states the private insurance rate is 75% about. Correct? You told.
The percentage of people who are insured by private
Yes.
insurance? Maybe 60 to 70, yeah.
I don't know the exact number in Turkey, but I think then maybe between 5 and not 10%, not possible. So, but the system, the government is encouraging people and also the markets for establishing more private institutions and insurances. There will be a change, I think, in maybe in 10 years.
Okay, and Noreen, just give you the opportunity very briefly to give us what could happen. We have a general election here in the next month. If the perfect person came into the Home Office or the Department of Health, what should they do with our current system to rebuild it as you described it?
I think that they need to rebuild it very, very quickly and start to give guidance, instructions. Let's have a drug strategy. You know, we review the last one, what works and what doesn't. It's very, very patchy at the moment. And I would think that, you know, if the person came into the Home Office, that they would actually spend their time going around talking to service users and talking to providers, because I think that's the area where you'll get the honesty. But it is, and maybe it's about time that, you know, we started to bring RG UK back up. We've not had a meeting for at least 18 months, and start to get together as providers and some service users and start to put some pressure on once again, and, you know, hopefully Brexit will be out of the way a bit.
Okay, all our hopes in Brexit. So what we've got there in terms of our addiction treatment systems is, as I said out the front, the 3 very different histories, and I think if you replicated that from any number of countries around the world, you'd hear about very different histories and cultures of treatment and very different sets of challenges and constraints in building the perfect system. So, any contributions or reflections from the floor on what you've heard from these 3 countries, or what do you think about recovery-oriented systems and how to build them? Gentlemen here, I'll bring the...
Hello, I'm Philippe. I'm a psychologist from France. And to lift your depression, Noreen, it's much worse in France. Much, much worse.
you have an election as well, so...
Yeah, but this is terrible too. But anyway, about addiction. We just have the harm reduction model over there. There is no abstinence model. Rehabs, we don't have that. Actually, I'm here in England to talking to a UK clinic to open a French program for the French, because in France, like in Turkey, the government controls the whole story with a single-minded system, harm reduction, you can't open a structure with a different model approach. And that's been going on like that for a long time. We see movement of improvement. We got many 12-step meetings in Paris, not as much in the country, but a lot in Paris. But this is not. I mean, the psychiatric model is so strong, with in the hospital, so the addiction system, the way it works economically is like the budget of the addiction unit in a hospital is budget for the next year is determined by the number of consultation they do.
Yeah.
So they have no interest in sending people to mutual aid therapy.
Yeah.
They just want to keep them, and they I was an intern with psychiatrists during my studies, and they just keep renewing the prescription, which are often 2 pages, and they keep patients for like 10, 20 years, and that's the way it is. So it's bad, but it's much better here.
Let's hope that cheers Noreen up, because we were saying in terms of the funding systems in the UK, they don't incentivize providers to move people on towards recovery. Sounds like your funding systems incentivize the opposite direction. Keep them not recovered, and you will get more funding.
It chronicises the addiction.
We were going to have a speaker here on the panel from France, because we think it's an interesting country and an interesting history. I remember I did some work in France in the 90s, and what you said there was very much how I experienced it. The psychiatric profession was very dominant, has always been dominant in the French system. Before the 90s, it dominated in terms of non-prescribing psychiatry. Yeah? So France was one of the late adopters of methadone schemes or substitute prescribing schemes, and I think it was buprenorphine in France. Yeah, suddenly the profession moved to a substitution treatment model. I can't remember exactly when. I think maybe the mid-90s. And you're saying now that is the dominant form of treatment. Yeah, is substitute prescribing.
Yeah, methadone. All those substitutes, but they not over here. They use those things as detox or short term.
To some extent, that's the model. Yeah, but we have the same experience. We have large percentage of patients who are now 40, 50, 60 years old who have been on substitution treatment for decades.
Yeah. In France, it's on. They keep them on those things for forever.
Yeah.
They don't know. The thing is, they don't know how to replace substitutes because they have no programs.
Yeah.
That's the only thing they can do.
There's no route out. Yeah.
If you don't have a program, a containing program for those people, what do you do? A part of giving them drugs, substitutions.
I'm going to look around. Yeah, that's right. Repeat business. I'm going to look around the room for somebody from a country where things are going well. Hands up. Sir, please cheer us up.
Hi, I'm Lucas from the Netherlands.
Welcome, Lucas.
Yeah, we're very luxurious in terms of health insurance. Everybody's obligated to have an health insurance, and everything is paid by the health insurance. And if it's not paid by the health insurance, like for instance we're doing also beneath 16, and it's paid by the local government. With massive investments in healthcare. So I think we're very lucky, and we're here now for international purposes, and the funding and insurances is very difficult. So it comes to then private clients, which is of course very sorry for people we cannot help.
Yeah, but provision in the Netherlands is integrated and has good recovery results. Or?
It does have very good recovery results. Although I also recognize some of the what you just explained from the French situation, and it is we have a sort of traditional mental health care and addiction health care, which is very psychological driven and keeping people very, very long in treatment, usually outpatient treatment, once a week, once every 2 weeks, and more intensive daycare programs and 12-step programs that really are on recovery, usually, of course, abstinence-based, or at least make a very thorough intervention to give a bit more of chance and perspective on back to real life, in which of also what the American speaker said, Raymond, is very important then to come up with, okay, where do you go from there? And not only in your recovery, but also in going to work. It's a new social network, hanging up with a community and finances, etc., etc.
Thank you very much for that. It's systems work, and I think it's something Raymond said earlier as well, is when the investment is right, the funding systems are right, and the professional structures are right, then systems can produce great results, and that is the objective. Now we're past 3:30. We're into the coffee break, but anybody else want to give a reflection on these discussions before I conclude? I think I answered my own question there by saying we're in the coffee break. But can you join me in thanking the presenters, and thank you for your contribution.